Hello, everyone. Welcome back. So, the whole point of this podcast was to disseminate out knowledge, modernize education, and overall just talk to experts. It's incumbent upon us to talk to the experts that impact our care and the research and overall how we can improve patient outcomes. Today, we truly have an exceptional guest who is Dr. Adam Pyle. He's a base hospital physician and he has expertise that spans multiple disciplines and he worked on several continents. Not only does he bring a wealth of experience from working in diverse healthcare settings around the world, he's also an expert in sports medicine, artificial intelligence research, and most importantly, we discuss patient handover and communication strategies. Dr. Pyle is passionate about optimizing patient outcomes, and he believes that effective communication and seamless transition of care are absolutely crucial in achieving that goal. He's here today to share his insights on how paramedics can improve their communication skills, master the art of patient handover, and ultimately provide the best possible care to their patients. We hope you enjoy.
Necessarily comfortable with other groups, right? So no cross-pollination occurs. And then I think the other disadvantage that happens is folks will get at that point a little bit blasé and a little bit cliched about the whole thing. Like, yeah, I understand. Good communication checkbox, right? But what are the elements that actually go into that, and what does that entail? And I think people are a little nervous, and when I say people now, I'm speaking mostly about physicians and early career physicians or med students or residents. They get a little nervous talking out loud because it sounds a little cliched, right? They're repeating things, they're asking for closed loop communication, and they feel like maybe they're going to get an eye roll, like, oh yes, here we go with the closed loop communication. But also because I think they're a little timid about their own knowledge level. And so they don't want to say something wrong and have an experienced nurse or paramedic or RT or what have you sort of think like, oh, this person doesn't know what they're doing. And so there are ways, I think, to break that down that are evidence-based. One is interprofessional simulation, right? So you bring multiple providers from different groups, with the barrier there being like getting them all in the same room, schedules aligning, money, right? Are people doing this on their off time? And the other way to sort of break that down or make people more comfortable with that is a non-judgmental debrief period for some of these codes or resuscitations. And the barriers to that are, you can't do it for everyone, right? It's just not time allowing in the emergency department to allow a debrief after every time there's a code or after every time something happens. But I think if you pick and choose your moments for those codes that were either what we call those high acuity, low incident events, right? So like they're very weird and wild, but they don't happen that often. So like the pregnant patient who comes into a resus, or the pediatric patient, like the special populations. Also for the ones that didn't go particularly well. I would argue there is a role there for like a hot debrief or a cold debrief or both in those scenarios. And sometimes folks feel like the debrief is punitive, so it also has to be done carefully, right? And in a nuanced manner where everyone's allowed to speak. But I think those are the things that we probably don't do as often as we should, or like unrecognized opportunities to improve communication.
It's interesting that you say that, like, and it shows the human side to it, because how you mentioned at the beginning, physicians are kind of reluctant to maybe go through this because they don't want to be perceived as giving inferior kind of communication and everything.
Yeah.
But from the paramedic perspective, I'm sure the vast majority will say it's intimidating and they're nervous as well to give that, right? And especially with the interprofessional training, like, we know that's a huge gap in the healthcare system. And again, all those barriers, like, how do you get all these schedules to align to practice one another? Because I always think, like, a sports team, they don't just split off the defense and the offense, then they're supposed to figure out in the game. So obviously we need to do it. Do you think it's hard once you break down the barriers of people getting engaged in patient handover and communication, it actually improves like outcomes? And
and I think we have evidence to suggest that that's the case. And I think that some of this comes with time with facility. Like, if you know the folks in the room, it is better. But because we're a little bit plug and play in our healthcare system, you're going to end up in a lot of different emergencies with a lot of different people. You don't necessarily know who they all are. And there's this false narrative in medicine that maybe the physicians are always the one whose skill set encompasses the skill set of all others. When the reality is, of course, that's not true, right? There are nurses and RTs who do certain things much, much better than the physicians in the room, and paramedics the same. And then the physician's role is by necessity limited to code leader or providing opinion on in-hospital care versus pre-hospital care. And so I think that the teams that do well, that perform well with Handover, either really know each other very well or have a templated formula that they follow that's been set up in advance. And I think that points to what the work that we're trying to do in the research world, to say let's take it out of the hands of the folks on the ground floor in the moment and say, well, we're going to use this template that everyone's going to do every time, and it may seem silly to some or checkboxy to others, but we know from the surgical literature and from other places where they do use checkbox sort of list format algorithms that safety and quality are improved when you force folks to go through certain key steps instead of just assuming that that's going to occur.
What kind of mnemonic do you use at Lakeridge?
So right now there is no mnemonic for Handover. When I teach Atmist and Sample, and depending on the situation, I think those are both reasonable choices. When I do pre-hospital work in the sports medicine world, they use Atmist and Sample. SBAR is also reasonable, but of course lacks some detail. There is, to my knowledge, not a world standard or even a Western medicine standard that works in all settings. Is there one that is preferred in the paramedic world?
Honestly, the one we do have is through Sunnybrook, and that's called IMIS AMBO.
Oh, yeah, you're right. Yeah.
So I remember first taking a patient there, and they're like, I already had my plan in my head how I was going to say it. And then they're like, do you mind following this template? And I remember looking at the wall. I'm like, that's brilliant, but I wasn't really too familiar with that. So you can see the gap here.
Yeah.
But otherwise, the only reason why I know about SBAR and the other kind of acronyms is just through my master's, because I don't believe that's well known in paramedicine.
No, I don't think it is. And I think worldwide it's more well known because I think there are folks in other countries who are using this because they just lack anything else. But you can imagine that the Sunnybrook one, for example, is, if I remember correctly, generated out of research on Handover. So should probably be a model for folks like myself when we're doing the research to follow, and we do draw from that research. Like, it is one of the references in our current EMS Handover pathway. But I also think that there is room for iterative process improvement on this because there is no standard at this point, and I think that we can sort of make it our own to a certain extent. I do think that we would all benefit from using one. Because the disadvantage of not using one, of course, is that it's very much inter-provider dependent then as to what you get. I also find that there is a gap on the side of the folks giving and taking the handover as to who is going to be giving and who is going to be receiving. So, by necessity, paramedics are often working in a dyad, right, in a pair. And they're trying to physically offload the patient while also logistically offloading the patient and talking through the handover. And different paramedics will have different ways of doing this, but often both paramedics have one piece of the puzzle. So one of them has the meds, or one of them spoke to the family, or one of them was doing vitals while the other one was taking history, which is okay. But in Handover, you can imagine that's not ideal. It would be best if it was one paramedic to one provider on the other end. And conversely, on the hospital side, it's not ideal to have 2-3 physicians in the room and then an RT and a charge nurse who's trying to document, and they're all kind of hearing a part of the story, and the triage nurse outside also heard part of the story, and bits are getting missed, or they assume that the meds list that was left at the front door has made it in, or that the call sheet has somehow been magically transported into the medical record and somebody has checked it, which is often not the case. And then there's that whole back end piece of the things that aren't life-threatening but still need to happen, like what's the health card number so we can pull this patient up, like those sorts of logistical gaps that make no difference to the actual resuscitation in the moment, but enable us to access the computer system. And I think those are the elements that make this more complicated. But I think if there was an approach that allowed for fewer providers to be involved in a one-step process of handover where the person in charge is getting the handover directly from the paramedic in charge, then that would be more ideal.
It's interesting you said that, because I noticed this just with your resus. You said, okay, let's move the patient over first. Then once we kind of settled everything, let's talk. And I found that so extraordinary, because it's like, it's honestly like a dog's breakfast, trying to give report, move the patient over, make sure lines don't get pulled.
Right.
And just thinking like anecdotally, and we're well aware of this, like just the fact that I give the same report multiple times to so many different providers. And you said it, I was like, my partner has the meds. I don't know what they are, because in the resus, I was at the head doing airway and they went and talked to the family. So what do you think is the most common information that's omitted that could compromise patient safety?
Yeah, that's a good question, I think. Well, so first I would say, slow is smooth and smooth is fast, right? So if you have the time to do it in the manner that you just described, where you're offloading the patient first and worrying about the IV placement and hooking them up to ECG and blood pressure cuff and that sort of thing, and then you're giving handover, or conversely, you're giving handover and then offloading the patient first. But as long as they're not having a simultaneous interaction, then you're less likely to miss things. But I find that the things that get missed are the things that are written down. So the story often gets transmitted, but the list of medications, the things that happened that you have written down on whatever it is that you've used to document, either electronic or paper, I find that those are the bits that are missed. And I think it's out of an assumption that somebody has passed that on to you at some point. But unfortunately, that I think rarely occurs in real time, especially with the electronic medical record, right? Because we're not looking at the screen and there's a delay in uploading it and so forth. I would say the other thing that gets missed a lot is the initial call from the field. And I think that is a very important call. And I think since we've had that ability to sort of patch in from the field on the patch phone and talk to folks in the hospital and get them prepared, we've had a much better in-hospital response. We collect a team, we get all gowned up. During COVID, this was very important. We put on isolation-related PPE stuff. If it's a pediatric case, maybe pediatrics comes down and joins us in the emergency department, right? And that all takes 5 minutes. So getting the call from the field is important. The unfortunate downside of that is that call from the field is often a quick call with very few details. It would probably also benefit from a very limited SBAR style standardized handover acronym. And then there are the limitations of like, oh, it was breaking up, it was in the rain, there was background noise. Did they say 74 or 47 years old? Those sorts of things. So I think it would benefit from either a standardized approach, with a clear call, which can't always be done, of course, or some sort of electronic method of hearing about it on the emerge end, or data transfer over, which I'm sure is coming, but because I know we've already moved from paper to EMR kind of input of paramedic data, but I think it could stand to be smoothed out a little further.
Because, correct me if I'm wrong, you're doing AI research too, right?
So yes, but not with Jen. But we are engaged in AI research in the hospital. Yeah,
that's incredible. Because I'm thinking, just like in a perfect world, like imagine you took the call dispatch information and automatically got transmitted to the hospital.
Yeah.
Even though we know it may not be truly accurate, but at least okay, this is the patient's rough age, this is their complaints, and it doesn't saturate us with tasks, because like it's hard to give a report to the receiving hospital if you're still resussing, and especially too with the other paramedic driving, it's not recommended for them to radio in, so you can see the gap there. But that is good to know. Like it would be nice to know what was the incident history and obviously their age, because anecdotally, like you said, like sometimes it got misconstrued that it was an 8-year-old versus an 80.
Yeah. So you just want to have the right folks in the room and the right kind of preparation on the hospital side. That would be helpful.
What do you think is different about patient handover between pediatric patients, like a sick pediatric, versus an adult patient?
Yeah, I think that the peds patients, and I always talk about this with residents and medical students, without being too macabre about the whole thing, but the expectation is that they'll live. Whereas that is not always the expectation with the 80-year-old with prolonged downtime and the family wasn't even sure they were a DNR or not. There are natural logistical components to that make it not less urgent, but a different risk stratification from the in-hospital setting. Uh, the other thing is pediatric patients don't tend to get into acute care situations with as great frequency as adults. And so when they do, the doses are different, the weights are different, the providers in the room are different, and the expectations and outcomes are different. And by necessity, the problems tend to be less degenerative and age-related and more focused on trauma and congenital conditions and that sort of thing, which are things that we face less because they're low incident events, right? They're low frequency events. And so we all get very nervous in hospital. It causes us to want to have different providers in the room. And whereas the adult resuscitation is quite a standard for us that we do quite regularly, I would say the pediatric presentation is a very focused special population. The handover, I think, doesn't differ too much, although the things I just mentioned matter, like the weight. But the other thing that matters, I would argue quite a lot, is the presence or absence of adults and where they are located, right? So were the parents there? Are they on their way in? Are they with you right now? Can they provide further history? Are they actually hindering the resuscitation in some way? Is there a concern about abuse? Because that is a special population consideration as well. Are police coming in with this child, right? Those things happen with higher frequency in the pediatric population than in the sort of nursing home population that we get as arrests as well. So that's how we think about it on our side. I'm sure on your side, the parents are also, both their presence is both an advantage and a disadvantage, I'm sure, during their resuscitation.
Yeah, tell me what you think of this, because we were taught, like, obviously there's some research to support, like, if the family wants to watch it, it's
Mm-hmm.
beneficial for them in the
Yeah.
long term. But
Yeah.
obviously, if they're not coping well, they don't
Yeah.
have to stay.
Yeah.
So we try to have like a liaison person. It's like, I'm your point of contact. You talk to me at any point. We'll ask any
Yeah.
questions.
Yeah.
And
Yeah.
feel welcome to watch. But if there's a
Yeah.
hindrance, then obviously we have to take care of that.
Yeah, we offer it always because I think we're all aware of that same research. We always assign a person, a social worker or an extra nurse, to the parent in for two reasons, like really for the discussion and the nuance of what's going on, but also for in case they pass out or faint or have a medical issue, which has happened, excuse me, not infrequently in the past. So you want to make sure they have a chair and there's a quiet area, and maybe they don't come in right at the beginning when things are a little bit hairy. Maybe they come in when it's in the more controlled mid-resuscitation phase. And do they have a support person? And then what's going to happen on the back end when the resuscitation is over, either successfully or unsuccessfully? So I think it does depend on your system resources in the in-hospital setting. But at a minimum, I would say they need to be in a controlled portion of that resuscitation area, so not directly beside anyone who's trying to do things, and in a chair, not sort of standing where they can pass out and fall and hit their head, and with some person assigned to them.
I love that it's so coordinated, and paramedics appreciate this, that everyone has a role and everyone's there for a purpose.
Mm-hmm.
And like paramedics really like take notice of that. Like I remember so many times social workers there supporting the family and everything. And that means a lot to families, and just seeing that, have that extra care for them, because they're patient too in this horrible circumstance.
Yeah, the downside, I think, is too many people in the room and too much talking. But that goes back to our earlier conversation of, non-essential folks can be out of the room. Essential but not active folks, like those awaiting their turn at CPR, can be in the room but don't by necessity have to talk, right? And then the folks who have to talk are the folks managing airway, the folks managing meds, the folks running the code, the paramedics, and they only have to talk in that manner where people are engaged in closed loop communication and reflecting back on what the actual details are of the case. It doesn't have to be simultaneous conversations about four different things. And I think the best case scenarios or the best codes are codes where that occurs, and there's lots of reflection back, there's lots of review. Can I confirm that this was given? Yes, it was given. Okay, and moving on. And I think we all know, like, the 2 minute CPR round is a lot of time. And when I talk in simulation, by the time you're around 2 or 3 years CPR, the room has gotten a lot quieter, and you can start to plan for those things like, okay, before the next pulse and rhythm check, we're going to do X, Y, and Z. Can I get confirmation when that's done? And folks kind of scurry off and do their thing, and then they feed back that those things have been done. I think that's the opportunity for smoother communication. The initial 2 minutes are often the roughest 2 minutes. And again, slow is smooth, smooth is fast. So if you can move your way through the first 2 minutes with priorities, like yes, CPR is in progress, and yes, the patient has to be offloaded, but we don't have to get handover at exactly the same time that is occurring, right? Necessarily, or one person can be doing that while the other person is giving handover. It doesn't have to be the provider who's lifting. So I think that the opportunities for what's missing in our healthcare provider communication during resuscitation pathway is those periods of quiet and the discrete skills related to my role is just this, and I don't have to talk beyond that role. I just have to listen.
We were talking about this offline, and
Mm.
it's amazing to watch you run a recess because you're at
Thank
the
you.
head, and it's
Mhm.
awesome to see like you're controlled, very good communication and leadership, and you check in on everyone. Because I remember
Mhm.
you're just like, okay, Epi was giving at this time, correct? What's everyone thinking now?
Yeah.
Even with the PPE stuff during COVID, or even if
Mhm.
we're suspecting like meningitis, I remember you're like, okay, everyone has the appropriate PPE on. Is everyone okay? And who's getting tired in CPR?
Yeah.
So do you think it's ideal to have the team leader, but everyone has that comfortability to have input and talk?
Yeah, so there's two things I think on that piece. I think there's a good body of evidence, and when I was at St. Michael's Hospital downtown, they would talk about this a lot, of the encouragement of mini teams within the broader whole. And I don't mean that there are small groups of people who are engaged in conversation that are drowning out the team leader. What I mean is that the CPR folks, for example, there's 2 or 3 of them, and they know that they're going to take over next. And this can be done with either, one word or quick eye glances. Or you're like, you're going to take over next. Okay. On the next one, you'll take over for me. The next pulse and rhythm check, or I'm getting tired. I just need you to take over now. Like, this can be a whispered one sentence kind of thing. But if they've engaged in a mini team, then the team leader can cognitively offload that CPR change is going to occur regardless of their input. And I think that's fair, right? That's a good example of delegation for those groups. And it can't happen in the moment. It has to have happened in advance, right? These folks just have to know, like, oh, I'm part of the CPR team today because I'm on code blue, and it's likely going to be me as a junior member who's potentially doing CPR. And so we'll organize ourselves. So I think that's the first part, that teams need to know, and then they feel comfortable and empowered to do that on themselves. The other part is, if you create a room and an environment where everyone's comfortable and nobody's ego is at play here, and this is again especially important in the learner environment where, at academic institutions, the person at the head of the bed might be a second year resident or might be a fifth year fellow, right? You have no idea who that person is, and they don't necessarily have their badge exposed, or during PPE times, they don't necessarily have the sticker on, although there is a whole world of research around identification during codes and how we should all have our stickers on. Um, but those folks also, because you don't know who they are, you want to empower them to be able to say things that they think are important in the moment, and to invite that feedback as the team leader so that you're not missing anything, for one, right? You want everyone to lend their skill set to your resuscitation, but also so that you don't get the flip side of things where the resuscitation ends poorly. The outcome for the patient is that unfortunately they pass away, and somebody at the back of the room, probably a junior person, says, oh, if I had only spoken up, and maybe I said, if I had suggested magnesium, I had this idea in my head about magnesium, maybe that patient would have lived. And now I'm going to carry that around with me because I didn't get a chance to talk about it, and I feel really terrible about it. And you would not want to have anyone in the room feel that that's the case, especially if you as the team leader knew that probably magnesium wasn't going to save this person, and you had already thought of it as well. And so you would like to ideally, and I try and do this, check in, especially near the end of these larger codes. Does anyone else have any thoughts? Oh, I'm opening the floor here. Does anyone have any ideas? And then that gives them the chance to say, what about magnesium? And then you can say, I appreciate that. I think, probably in this case, it's not going to be helpful, or it is going to be helpful. Let's give it a try and run it for 2 more minutes. And then those folks don't have to carry that with them later. Because I think that's sort of one of the worst case scenarios of an avoidable psychiatric or psychic injury or moral injury to the folks who are doing the resuscitation. I think those accumulate over time. A certain number or a certain amount of stress related to resuscitations and life-threatening situations, it is, by its nature going to occur. But I think that as much as we can minimize that burden on providers, of course, the better it will be for them, so that they don't accumulate, degrees of moral injury over time. And you just want to make sure that they have felt supported and heard so that they can continue to do their work. But by the same token, I often talk to residents about, the time you're going to make a mistake is not in the resuscitation necessarily. It's the first patient you see after the resuscitation. Because then you wander back to the low acuity zone and see a back pain who's been waiting 4 hours and is angry with you. And you're just feeling frustrated because they don't know where you just were in this resuscitation. You just discharge them home and you ignore the red flags and you don't think things through like that. I would argue is when you're more likely to make a mistake on the next patient you see, or the patient, 2 patients after that, because you're not in it. So take a moment, take 5 minutes if you need to, and do something else before you go back to your sort of low acuity job or your next patient. And I wonder, do paramedics do this also?
There's so much good wisdom in there that I want to break down. But yeah, like you said it best, like imagine you feel like you didn't give an optimal cardiac arrest or something's just lingering because you didn't have that chance to communicate it. Then your cortisol spiked and you're thinking through it. Then you still have to continue on with your job. So, and you're just thinking about it, then you maybe get ridiculed, maybe someone's being disrespectful, and you can see how that's morally distressing. Because for the longest time, and the system has vastly improved, you could do like a terrible trauma, pediatric cardiac arrest, then you're expected to go do a lift assist, like pick up a person off the ground, and you're just like, and they're, let's say, complaining, like you could see how that's distressing for people. So it's unique to see the human side of that, especially in physicians too. And I love that you mentioned the labels, because I remember years ago, before Sunnybrook had labels, I gave report to somebody that wasn't even a healthcare provider because we're in scrubs. So I'm like, okay. Or just walking in and you're like, okay, who's the respiratory therapist? Because I want to confirm the tubes in place and everything.
And it changes every month at the big academic centers, right? It could be completely different, within day to day. And those folks, are often very skilled folks, but the difference between a first-year postgraduate trainee and a 13th year postgraduate trainee can be unrecognizable, other than if they, clearly have it listed somewhere on their badge or on a sticker or over top of their scrubs, or they've stated it verbally. If you're all kind of behind masks and in full PPE and you can't do the sticker thing.
And I love that you mentioned too about asking everyone, like, does anyone else have any ideas? Because I've seen you do this, and I remember like when I first started, a physician did it, and it really changed the dynamics of the cardiac arrest. And you could tell they genuinely felt like they looked at everyone in the eye and said, do you have anything to add or anything that can change it? And from our perspective and any healthcare providers, like that's amazing that you have that consideration and everyone has that open opportunity.
Yeah. It's a psychological safety piece. We talk about it even during simulation. To be honest, I struggle with it during simulation because I think we've moved pretty far in the direction of psychological safety and making sure that folks aren't triggered by a past experience or a family member with a similar disorder from a medical perspective or something that's happened to them, at work. But the flip side of that is if there is a time for that discomfort, I would argue it's in simulation. So there is a certain amount or a certain expectation that when you're practicing in simulation, you're getting comfortable being uncomfortable so that in the moment you are not uncomfortable. And so that psychological safety piece, I think, is very important in real life. I would argue that it should be pushed a little bit in the simulation. Like people need to be prodded into action and made to feel a little uncomfortable. So then they're used to dealing with that discomfort, right? So that they're used to dealing with difficult choices in critical moments in the risk-free zone of simulation. And some of that comes from telling them like, hey, listen, I might be your supervisor or your academic superior in this case, who's filling out some evaluation on you. But in simulation, this is a safe space. right? So feel free to make mistakes. Don't feel like you're asking any stupid questions, right? Like that comes with that relationship. But then they should be pushed a little bit in simulation, I think, so that in the moment, that psychological safety piece will shine through because they're resilient from the previous training. It's hard to say where the line is on that, and there's a lot of research and simulation on where the line is on that, and how much folks should be pushed, and how much they should get comfortable being uncomfortable, or be forced to repetitively do procedures, or run codes in simulation, or run mega codes. But I think that research is intriguing to me. Because I do think that we are more cognizant of it now, but maybe the pendulum has swung too far in the let's make everyone feel safe direction, and that we do need to provoke learners a little bit for these life-threatening situations. I haven't seen it in the pre-hospital world as much. I think you folks do a good job of poking people and putting them in difficult situations, and your sim labs are quite good as well. So I think maybe, without knowing too much about it, I suspect that you're doing this a little maybe than the in-hospital folks are doing it. But I would urge medical curriculums, and St. Mike's again has a good Code Blue training system in their sim lab for this, to really push folks and force that comfort level in simulation so that it doesn't come up later.
It's amazing you mentioned all that, especially about like the human factors.
Mm-hmm.
Because correct me if I'm wrong, St. Mike's and Sunnybrook and sick kids, they
Mm-hmm.
look at a lot of like human factors, and like
Yeah,
how much did you move around in the
yeah,
resus room? How much
yeah,
space is wasted? And is
yeah,
there an optimal number of personnel for a resus?
yeah.
Do you think that's a huge gap in any other hospital, and we should be doing this more?
Yeah, I think we look to St. Mike's and Sunnybrook, and the work of folks like Chris Hicks at St. Mike's, who's done human factors work, and a number of other names. I don't want to forget to mention anyone, but I think we in the community look to those folks to say, what is the optimal number, and how should we best be communicating within the resuscitation, and what is the role of a trauma team leader, for example, and who can be a trauma team leader, what sort of special training would be required there, over and above your sort of usual emergency physician or trauma surgeon training, because those are the big soft skills that we talk about, that don't necessarily have to do with medical knowledge or certain defensiveness about your own medical knowledge, or making sure that you have all your ducks in a row, but they have more to do with speaking, relating to others, making sure that even though you yourself might find the checklist to be a little bit redundant, there are other folks in the room who don't know everything on that checklist, and you want to make sure we're all going through it. I think they faced this similar pushback in the surgical world when they started rolling out checklists for, counting instruments, and, pre-op and post-op checklists, where I think that the scrub nurses and the people who are there every day who make surgeries happen love these checklists. And I think initially, without casting aspersions, there was some pushback from older providers, probably mostly physicians, who felt like, well, I know all this and I'm doing it every time anyway. And that might be true, but not everyone in the room is as experienced as they are, or are doing that every time. And some things are slipping away the wayside. And, we're getting into routines that are, potentially harmful or suboptimal. So I think it does help to check in. That comes from a space where you can be humble, though, right? It comes from a space where you have to admit that you don't necessarily always come to work in the same frame of mind, or on your A game. There's stuff going on at home. You don't necessarily get along with everyone on the team perfectly. There is some history maybe there, and obviating the need for that cognitive load to fall directly on you, but rather to put it on a checklist or a routine or a schedule or an algorithm, as emergency providers often do, because we're very algorithmic and binary based, both pre-hospital and in hospital, is helpful, I would argue, and allows that space for people to be like, okay, well, we both do checklists, so let's do the checklist, right? Everyone understands the checklist. We're all on board with that. Let's do it together. And I think the more we can get into that for not every situation in medicine, because there are odd, weird outliers that you want to consider as well, but in specifically those acute care situations, the resuscitation situations that are by their nature very algorithmic, I think the better we're doing for patients. And I think there's ample evidence to suggest airway checklists, surgical checklists, etc., are always helpful for improving quality.
It's funny you mentioned the culture of healthcare. and especially maybe like stereotypically older physicians, and just
Mhm.
like they're working hard every day and they're just like, you're just adding more things that I'm already doing.
Yeah. Yeah.
But the evidence is clear that it's beneficial.
Mhm.
And this always stuck with me. One of my professors said this. He goes, "Do you know in any other profession that if you said we can't change stuff because of culture, they would laugh at you?"
Yeah.
In the
Yeah.
aviation industry, they'd be like, "You can't measure a culture. It's not
Yeah.
quantitative." And like, why is that a barrier? But in healthcare, it's hard to break down that barrier to improve the system, right?
Yeah, and I'm glad you brought up the aviation industry because I think, there's increasing awareness since Martin Bromley and the sort of the work that's come out of other countries on what the aviation industry can teach medicine about standardization. I think there's increased promulgation and awareness that we probably could move in that direction for acute care, ICU, pre-hospital type management, because there is probably a lot to learn from those folks. It's plug and play with them, right? Any pilot, any co-pilot could end up together on the same day. They might not know each other, but they have to rely on the fact that they will both respond similarly given any particular situation. And I would argue that plug and play situation also exists in healthcare. And I would like to know that the person managing the airway has a standard set of skills, and they would like to know that I have a standard set of skills, and that we can rely on each other to do that on a day-to-day basis. I think that the places that do this well, again, tend to be places where the providers are relying on heuristic frameworks, and everyone is expected to respond similarly in similar situations. And that leads to standardization, which leads to increased quality.
So, what got you interested in all this? Out of curiosity.
In emergency medicine,
Emergency medicine and patient handover and communication. Emergency medicine and patient handover and communication.
yeah, I think so. I think I've always had a little bit of as many physicians do, of an imposter complex, where we sort of get out there and we start practicing, and we wonder if our skills are up to snuff or if we're just sort of faking it till we make it. And that's probably looking a little bit too deeply into some people's psyche, but I think there are a lot of physicians and acute care physicians that do wonder that, especially early career physicians. And so for me, it was about a personal improvement part. It was about making sure that I was good enough to do this job, because I felt like I owed it to patients and other providers. I practiced in a number of different settings, and part of my education occurred in the States. I practiced in New Zealand for a year. My brother is an emergency physician also, and he practiced in the United States, and we often compare notes on systems issues. We've both done work in resource poor settings, and we both do teaching work. He does some stuff with FEMA and disaster management. He's done some stuff with the military, and then I have sort of a sports medicine, pre-hospital teaching role as well. So I think we draw from all those experiences, but inherently for me, and I suspect for him as well, it was about accumulating skills so that we felt that we were enough to do this job. It was a little bit of a, sort of a chip on our shoulder thing where we wanted to make sure that we were good enough. I always tell folks that he wanted to be a trauma surgeon, and I always wanted to be internal medicine, and then we both ended up in emergency medicine. I think what attracted to us to emergency medicine is, I really like the detective work, the puzzling out diagnoses, which I thought was happening on internal medicine floors, and it is. But the initial steps are taken to emerge. He was always interested in trauma medicine, but he likes talking to people and figuring out what happened. And by the time they're in the trauma surgeon's zone, they're often intubated and sedated. So I think he also was attracted to fixing people right at the front end or doing those initial steps. And so we've migrated to that area. And people will say like, oh, is that job hard, or do you see gross things? And I think the implication is, oh, you must have to deal with so many things. Well, if it was dealing with it, I don't think we would do it, right? If it was hard for us, if we didn't enjoy it, it's not the kind of medicine we would want to practice. But I think, luckily for both of us, myself and my brother, we're relatively inured to the more acute aspects of that care for whatever reason. And we really like the puzzling things out in real time in high pressure situations. And so it's probably the work we should be doing. I had also practiced primary care for a while. He has done some other things. We always find ourselves drawn back to the resuscitation environment, the team environment. I don't think I ever had, this sort of bent where I was going to be a surgeon and, a team of one and rely on myself. And I don't think I had the confidence for that, but I always felt like I wanted to work with a highly skilled set of providers who each have their own niche and sort of, lead the team forwards to help patients. And I think that when I got into that world, I then saw, as you have seen, that there's constant need for improvement, right? There's gaps, there's things we could be doing better across a very strained healthcare system, of which we are at the sharp point, right? We're at the tip. And so, as I'll tell residents and medical students, a lot of patients who get admitted to the hospital come in through the emergency department, right? You don't walk in and get admitted necessarily. You come in through the emergency department with a problem, or you come in by ambulance through the emergency department. And that's often the beginning of your healthcare journey. That's the doorway at the bottom of the hospital on the ground floor. And I think if we think about it from that perspective, the steps we take, the golden hour for trauma and sepsis and things like that are happening right up front. And it's incumbent that we get that right as providers, both yourself and myself, like the pre-hospital world and the in-hospital world, so that the rest of the patient care journey is already, off on the right foot. And when we unfortunately don't get it right, it impacts our colleagues on the admission services and the surgical services. It impacts the patients. And so the bits and pieces that go into handover and team dynamics and communication and softer skills and non-medical, non-fact-based, non-textbook-based skills are very important. And I think, because emergency medicine is so young, there's a lot of room for improvement in those realms, given that, the whole system of emergency medicine has really only been around for, 40 years at this point.
The key thing I got out of that, especially, was it's all iterative.
Yeah.
And we always have to improve, but that's hard for healthcare providers to hear, especially when they're tired. We're post-pandemic world.
Yeah.
If you could wave a magic wand, the best thing we could do today of all the evidence, what would the patient or the best patient handover experience look like to you, and just overall communication?
Yeah, so I think we're figuring that out as we speak, and I don't pretend certainly to have all the answers about the best patient handover experience and sorry, what was the second part? The best patient handover and
communication, team dynamics.
And communication, yeah. But I think that the end result of both of these is it will come from standardization and training. So it needs to be a framework that is evidence-based that we figure out through research. And then in its application, it needs to involve training, and that training probably is going to be heavily simulation focused, right? So whatever that handover piece looks like, whether it's the Sunnybrook model, which we spoke about earlier, and I think is very good, and we're modeling things after to a certain extent in our research, especially in Ontario. And if we end up going with something like that, that's fine, but as long as it works from an evidence-based perspective. And then from a communication standpoint, if we incorporate simulation and make sure that even though we have this model, it's not people pulling out a piece of paper or looking at a wall chart to make sure that they get it all right. It's part of what they do every day. Because they've run it in simulation, they know it takes, approximately 180 seconds or what have you, and it should be one person to person, and it should happen in a relatively quiet environment, and it shouldn't happen while you're doing three other things. As long as that standardization piece is worked out in advance in training and simulation, then that would be best. I think there are opportunities here that are hard for me to predict with AI and with electronic medical records, where we will probably see things go in the future to a model that integrates both of those pieces into this. So maybe we get something in advance that's written down, maybe based on chief complaint and provider response time, AI spits out a series of things that have already happened with the patient, right? Maybe AI perceives that multiple rounds of epi and shocks and things have been given. Maybe AI is getting feedback from an automatic CPR machine that's on scene, right? Maybe AI is predicting based on patient age and ECG what possible differentials we should already be thinking about. Maybe this all gets spit out in advance, and I'm just sort of throwing things out here. But I think we've all seen that that from a technological standpoint, the seamless transition between healthcare systems is always better for the patient in the end. So if primary care speaks to the hospital, if paramedics speak to primary care in the hospital, and we're all on the same system, that's better for folks. And there are countries that do this better than others. But whenever there is, sort of nationalized EMR or nationalized patient records that include the pre-hospital world, the in-hospital world, the primary care world, the outpatient, long-term care facility, the nursing and home care world, those folks do better. There's less waste in the system. There's less duplication of resources. There's better communication between providers, and patient outcomes are better. I think, we're moving in that direction in Canada. We're certainly not worst at this, but we aren't best either. And I think we can pull lessons from our tertiary care centers like Sunnybrook and St. Mike's as to how we could be doing this better in the community. But we can also pull from other countries that do this better with similar socialized medical systems like New Zealand, like Australia, like the UK. And I think that the other thing that we learn from them is how to provide services, and this is slightly off topic, but somewhat related. How do we provide services to a population that is not dense over a country that is very large? So it's easier, I would argue, to get good access to tertiary care specialists and have better EMR harmonization in Toronto than it is in Moose Factory, Ontario, because we are spread out and it's difficult for folks in areas that are less population dense to have access to care. I think that electronic medical records and AI and telehealth solutions that enable distance medicine to occur are an answer to that problem. And physician extenders or healthcare extenders in the form of physician assistants, NPs, advanced care paramedics in communities where there isn't necessarily a hospital or a specialist physician are probably the only answer to this problem, because we're not going to suddenly have the capacity to build large tertiary care centers in a disparate population base. And I think we need to investigate those more fulsomely in order to, ensure sustainability of the system. And there are countries that, like Australia or like New Zealand, that have similar challenges in terms of populations that are quite spread out, and they have solutions that we can maybe learn from.
Can you speak more to that? Like, what was the best part about being in New Zealand and just what Australia's model that we would love to integrate here?
Yeah, we do a good job, I think, with transport medicine. I think they probably do a better job. I think so I'm speaking about both New Zealand and Australia here, but their air ambulance, air transport system is quite robust. And I think there's a really good partnership that occurs there between paramedics and physicians that we could probably learn from and would ensure more seamless care for some of our folks in rural settings. I think the other thing that New Zealand specifically does that I really enjoyed while I was there is they have essentially a national level EMR. So things travel with patients. If you move from one part of the country to another, your records move with you. And there is a really good integration between primary care and the hospital setting through, emails back and forth with consultants, through the sharing of records and data in a way that unfortunately we don't have here, because we have kind of a patchwork EMR system in Canada and even within Ontario, multiple different hospitals and multiple EMRs. We're getting better at this because we've sunk a lot of money into it at the governmental level. But I still think there's significant room to improve on making sure that data follows the patient, because otherwise, every time they go to a new hospital, every time they move, every time they see a new specialist, there's a lot of reinventing the wheel that happens because they can't access old records, so they repeat imaging, they repeat blood work, and so I think that's probably a gap. Specifically for emergency medicine, there were pros and cons to being in New Zealand, but one of the things that I like there is they were very pragmatic about the way in which they practice. So I think there's a tendency, and I'll be careful here, but there's a tendency in Western systems, with the states being sort of probably the worst one of this, to be very risk averse. Which leads to a ton of testing, potentially to the harm or detriment of patients, and a more careful and judicious approach that incorporates risk is what's been adopted mostly in Canada, and we've seen a lot of this work come out of Ottawa with Canadian CT head rules and C-spine rules, and avoidance of imaging based on clinical rules that have been validated in research. And I think New Zealand has taken this even more to an extreme. Their system has a tendency, unfortunately, to be a little bit paternalistic, where the shared decision making between patients and doctors is more heavily weighted towards what does the doctor think. But in general, I think being pragmatic has got to be the way it goes for the sustainability of any kind of single payer system. Otherwise, it becomes very cumbersome. It becomes very expensive. And there's a lot of non-evidence-based, non-choosing wisely testing and treatment that goes on. I think as how this applies to the pre-hospital world, and I saw this in New Zealand and to a certain extent Australia as well, is, and we're seeing it with the IMPACT program, there's a lot that paramedics can do and see and treat, and a lot of judgments they can make that are probably not tapped into as much as they could be, in terms of who can be diverted, who can stay at home, who can receive treatment on scene, who can receive close follow-up with a primary care practitioner the next day, those sorts of pieces. That are probably unrealized opportunities to save money, rather than it being, a transport-based system, right? You have called us, your only destination can be the hospital. And so I would love to see that sort of thing expanded in Canada, alongside telehealth options and video options, and people can have touch points with the system and access care without necessarily overburdening an in-hospital system or an imaging system that is already massively overburdened.
Do they do more training, like interprofessional training in healthcare providers in New Zealand or Australia?
No, they don't, or not from what I saw. In the outpatient setting. In the inpatient setting, I think they are a little more integrated, but I think it comes from an overlapping of skill sets more than anything else. Like the example I would give, is that most phlebotomy here in the in-hospital setting is done by phlebotomists, right? People who come and their sole role is to take blood. Whereas in the New Zealand system, many providers can take blood, doctors, learners, nurses, right? And so you can imagine that if many people can do it, your gap in time to get that blood taken tends to be potentially shorter. So I think there's that sort of overlap that occurs, which is nice because many people can do many different roles. But no, I'm not sure to what they owe the degree to which their system is more seamless. I think it comes more from oversight at the government or district health board level, where they're addressing population needs from a district or geographical basis, as opposed to from an individual hospital basis. So like, where is the nearest cath lab? Well, it's there. Well, that's going to serve this population. So if it is going to serve this population, that means all that population has to have access to that cath lab. So what's going to happen if they need it and it's overnight, or it's on the weekend, or they're far away, or they need to go by helicopter, or that sort of thing. So I think they think more in those terms, which I think is very reasonable. I think not to cast aspersions about our own system, but I think we have solutions for these problems, but ours have come up more on an ad hoc basis. So I remember practicing in Moose Factory and having several possible destinations of tertiary care for people to be shipped to, and making numerous calls in order to make that happen. I think we'd all agree if there was seamless or sort of one pathway transition points, it would be easier than having providers in resource austere settings having to call around and negotiate in order to have folks seen.
If you could train as much as you want, how often do you think healthcare providers should train and do simulation to maintain that proficiency?
That's also a good question. I think it varies depending on their discipline and their level of experience. So I think residents and medical students should train often. And by often, I mean, if you're in a rotation like internal medicine, weekly, I think is very reasonable. For the period of time that you're there, or the ICU, or you're one of those acute care settings, the emergency department. If you're talking about respiratory therapists and nurses, they engage in a lot of like sort of in-service stuff on new devices, new pumps, new airway supplies, that sort of thing. But interprofessional simulation with other providers. As I mentioned, it's hard to get them all in the same room. The way we do it, because I also do simulation work where we are, is we do it monthly, but not everyone shows up monthly, right? So you have the opportunity to attend simulations at least monthly, as well as your sort of your standard alphabet soup courses that you take whenever you take, like ACLS and PALS and ATLS. So this is over and above that. So you have the opportunity to go monthly. And I know other systems sort of do this on a regular cadence as well, like Scarborough does it this way. But you don't all have to go. Now, prescriptively, if you are younger, newer, or you've had performance issues in a certain area, you might be asked to go. But in general, it's on a voluntary basis. I think that you'll probably realize that what happens then is folks who are interested and probably need this training less go regularly, and folks who are uninterested and probably need the training more go less frequently. And so the buy-in piece is hard. There's a lot of burnout in medicine, as you know, and people's spare time is important and to be guarded. I think that's another lesson we can learn from sort of our Southern Hemisphere colleagues is they have protected time, right, as part of the work they do specifically for research and education. And so you have to show up on those days. What you choose to do on them is up to you. And so you self-guide your own learning. Do you want to spend that time on research? Do you want to spend it on recertification? Do you want to spend it on simulation? But you won't be working on the floor that day, right? You'll be doing something else. And I think that is so valuable. But it's hard to imagine a spot for it in our current setting where people are getting pulled in a million different directions. But baking it into the system, I think, is very important. And I think that, we've had good uptake from physicians when it's done correctly, who really value that training, especially newer physicians or physicians in difficulty, because they know that it's a safe space to improve skills. It's not punitive. And so I think it has to be done through that lens. Like, it has to be done in a manner that makes them feel that they're not being judged and that they're upskilling, voluntarily, and it all towards the benefit of patient care, and not necessarily because something bad happened or because you have to check a box or because you have to do these modules, because otherwise you won't get your credentials back this year.
It's a hard stigma to kind of break
Yeah,
through, and
it
just
is.
making sure patient safety and teamwork.
Yeah.
I can
Yeah.
appreciate that. And I know an Australian pre-hospital doctor, an emerge doctor, and she told me that she has allocated time each year
Yeah.
to research and educate and
Yeah.
expand her knowledge base. And I was like, what an incredible system
Yeah.
they
Yeah.
have then.
Yeah, I agree. Yeah.
Out of curiosity, do you film the simulation so if someone can attend, they can see subsequently like what occurred?
Yeah, we have. There are pros and cons to this also, as you can imagine. So when we have filmed them, we have tended to do it for the folks in the room to watch themselves. So it's a self-critique. Did you know this is what you looked like, right? You can see how you were at the head of the bed here, but when you walked around to the side, all of a sudden you couldn't see what was going on with the airway. So maybe you stay over or, around the foot of the bed or the head of the bed, right? So I think there are aspects of that, of self-critique and self-evaluation, like in sports, right? The next day, armchair quarterback stuff that happens on Monday. But the risk you run, I think, is that folks feel like others are going to critique their performance later if it's all recorded, and there's a performative element then, and so they act in an artificial manner, and you don't want that. So you want them to feel like it's a safe spot and that none of this necessarily goes anywhere. In the same way that when you're discussing, what used to be colloquially referred to as morbidity and mortality rounds, but now is often called quality improvement rounds, but where you're discussing cases that went in a suboptimal manner. The folks in the room have to feel like that's a judgment-free zone where patient and physician names have potentially been de-identified, and you're discussing the case for the purposes of quality improvement, not necessarily judging the choices that were made in the moment. Because in the crucible, you want them to perform and feel free to make mistakes and not perform in an artificial way, that they would not perform like in real life. So I think it's risky to show it to others. The other thing about this, and I know this from didactic lectures which are recorded, is if you record them and say you can watch them at home, nobody will come. right? And also don't watch them. So, and I don't mean nobody, but there is a tendency to put that at the bottom of your list of to-do things that week or that month or that year. And without being uncomfortable and in the moment and in that setting, a lot of what the point of the simulation is lost. So yes, I think it's a tool to record them, especially with learners, to allow them to see how it looked. I would argue that the routine recording for learning purposes probably doesn't satisfy the goal of learning as well as we might hope.
I commend you trying to solve all this and push simulation forward, because it is a hard problem to kind
Yeah.
of get everyone interconnected and remove these barriers.
Yeah.
To operationalize this, and obviously I won't be talking time.
No
Let's say we'll tie it all in. I'm coming to you with a cardiac arrest from the field. We'll say it's a 60-year-old patient and they're intubated. We've given epi and we arrive at the emerge. What's the first thing you're trying to think about and coordinate?
Yeah. So the first thing that happens is probably before you even get there, right? I'd like to know that we have all the providers there. We're prepared with the drugs or equipment that we think we might need, ultrasound machine, airway supplies, etc., and that the right folks are in the room, and then that all those folks have taken a deep breath, right? And I'm saying that kind of tongue in cheek, but what I mean is they haven't just run in and heard the story. They're all standing there next to their supplies and waiting for these folks to come in. Now I know that's idealized and it can't always happen that way, but I think dedicating a code team, as many hospitals do, or having some advance notice, as we do with patch calls, is the best way to have that occur. And then once folks come in, for me, it's the first look, right? How do the paramedics look? How does the patient look, right? Are you wet and covered in blood? Are you, harried and stressed out? Or are you calmly going about your business because this is a well-controlled resuscitation that is happening, and has been happening in this manner probably for several minutes now? Or did something just happen on the ramp on the way? So for me, it's that first clinical gestalt. And part of that is because we don't always have all the information in advance. So I like that first look to kind of glean what's occurring from your folks' perspective. And then the next thing for me is, how are we going to engage in this handover? And this is the bit that I think you and I both wish was more seamless, but is it going to happen before we load the patient on? Is it going to happen after the patient is loaded on? Or is it potentially two parts? So like, give me a quick S-bar, we'll load the patient off, and then we'll go into a more detailed history. And I think the answers to that, we don't know with any certainty yet. But that's the next thing I worry about, right? Because I think we're all very anxious to okay, let's get going, let's get the patient moved off and hear the story. But those things all can't happen simultaneously.
We're all saturated with tasks, and that diminishes quality.
Yeah.
How would you want to coordinate the best means possible if someone's intubated from our stretcher to the in-hospital setting?
Yeah, so the first thing I would say about that is it can't be in a rushed manner. I think we've all seen tubes get pulled and things go poorly when that happens. So I think it has to be carefully prepped. Who's going to do the lifting and the moving? Where is everyone going to stand? Who's managing the airway during this procedure? And whether that's a paramedic or a respiratory therapist at the head of the bed in our center, or whether it's nurses, pulling folks over on a sheet and paramedics on the other side. I think those roles and that process, when it is rushed, has a tendency to go very poorly. I think when it is happening in a calm manner, it doesn't necessarily need to take a lot of time, but that 30 seconds or 45 seconds, which feels interminable in the moment, just to set all that up, is important. And of course, then it relies on what's at the other end of that tube and what's at the other end of the monitor, right? So are we hot swapping to our monitor? Are we moving to, a ventilator? Is RT going to take a look at all this first, or whoever's managing the airway going to take a look first? Is it an iGel in place, which, means that we don't necessarily need to be as careful with, tubes and things and hooking up to respirators? I think those decisions need to be made a little bit in advance, like 30, 45 seconds in advance, and then we can move the patient over.
The defib pads. And I'm sure you can speak to this. There's a huge gap that our equipment doesn't coordinate with yours, and that prolongs time, and it's issues and it's waste. It would be nice if it's seamless. Our monitor pads could just transition right to yours, so we minimize that gap.
100%.
So if we switch pads and they're in ventricular fibrillation, and I say I've given 2 rounds of lidocaine, 4 rounds of epinephrine, what are you thinking from a patient perspective about that?
Yeah. Are you heading towards a conversation about the dual sequential?
Yeah.
Yeah. So I think that there is maybe potentially an advantage here where you already have them hooked up to one set of pads and you can hook them up to a second set of pads, maybe, because that's the potential barrier. So I do sort of think in my head, like, as rare as this does happen, like, are we going to do that sort of a setup? In which case, let's maybe not be too hasty and uncoupling your folks' pads and recoupling our pads. But what I think about in those settings is I like the fact that meds have already been given, like lidocaine. I love that you can give that in the field now. I think it would be great if you could expand that to include other drugs, but I'm sure that's coming at some point. I know trials have been run on lidocaine, and I'm aware that you folks had that research for a little while. I like the fact that you have probably already done a lot of the things that we would do in hospital. So for me, because I know your systems a little bit and I know that you've given Lido, I'm probably drawing up other non-Lido drugs in the background, maybe even before you get there, which is great. So I think all of that is to our advantage, like ours and yours advantage in helping the patients. But only recently, and I'll say recently, like the last 6 months to a year, have I really considered that double setup, and the fact that your pads and our pads don't mesh, but maybe we want to leave all the pads on everyone until we kind of sort this out. I do think it's important to time it, obviously, between pulse and rhythm checks, right? So we don't want to be doing CPR and sort of switching them over. And if we can get a pulse and rhythm check while they're still on your bed, then I know we have 2 minutes until the next one, right? And we can move folks over in a more careful manner at that time. So I think that timing is important as well as the timing of epi. I still see providers, and this is no shame on anyone who's doing it, but I still see providers who are giving sort of full resuscitation dose epi at a period of time where maybe somebody had ROSC and it just went unnoticed, because we shocked them and we immediately jumped back on the chest. And I just would like to see that timing of epi optimized a little more. So to answer your original question, what am I thinking about in those circumstances? I'm thinking about 2 sets of pads. I'm thinking about other drugs for arrhythmia, and I'm thinking about epi timing.
Preferentially, what drugs are you thinking of? I know paramedics love to hear this perspective.
Yeah, so in that particular scenario, I'm thinking of amiodarone sometimes. I'm thinking of magnesium. I'm thinking of calcium, from the point of view of, like, what are the chances this was torsade or a QT prolongation related issue. I'm not so much thinking of bicarb anymore as a result of recent research on those sorts of things, although we are a dialysis center. So, there is a patient population that I would argue maybe could still benefit. I think that the other thing that I'm thinking of in that moment is pre-charging, knowing that pulse and rhythm checks are coming up, because that tends to be a barrier. So if I hear VFib or VTAC coming in on the patch call, already in my head, I'm sort of pre-triggered that this is a situation where shocks might be delivered within the first 45 seconds of.
So correct me if I'm wrong, because lidocaine and amio has been like researched for a long time. Sometimes amio comes on top, sometimes lidocaine comes on top.
Yeah.
It's statistically significant for amio sometimes, but not clinically.
Yeah.
We carry lidocaine in our catchment area. Can you see amio being more efficacious in other, like, certain circumstances, or lidocaine sufficient?
I would hesitate to say more, because I think I'm aware of the same evidence as you are, that it's kind of neck and neck, and the benefit for either of these isn't great, except if you are having abnormal rhythms with a pulse eventually, right? Like if you're looking to treat someone who keeps going in and out of these abnormal rhythms. And often the reality is they both get given, and to some patients who still have refractory arrhythmias afterwards. I think that, if we spoke to cardiologists, they would come out very in favor of amiodarone, and potentially, without putting words in the mouths of internists or ICU, that they may be less inclined to give that. We all have, one-off stories of, like, oh, amio caused my patient to become very hypotensive, and then they needed, other intervention, and Lido didn't maybe as much, or Lido was actually caused them to have a different arrhythmia, and then that was a problem. So these are very anecdotal, obviously. So I think we need more research on these topics, as we always wish we had. But the reality is that probably in patients who are very acutely unwell, neither of these particularly help. In patients who are survivable and just have, abnormal rhythms, there is a back and forth on which is potentially better for which rhythms, and which ones end up on top. And I'd love to see the toolbox for paramedics increase, which I think is the real question here, right? Like I'm always, when dealing with patch calls and stuff, sort of asking folks, well, like, what do you have? Are you a PCP crew? Are you an ACP crew? Or, what do you have the ability to give there? And I'd love to see that pre-hospital toolbox increase, because I think that's potentially where the real money lies in this problem. I think the choices, we could split hairs on the choices, but the timing would be better. If we can get a lot of stuff up front, we could potentially help more folks, I would argue.
The reason why I asked that, I love that you said it too, because some docs will pick amio, some docs will pick light, depending on every clinical situation. Because historically, anecdotally, paramedics patch in, and some physicians will say, hey, do you have amio?
Yeah.
Already in their head, they're like, oh, why am I giving lidocaine if it's perceived to be inferior if I'm getting ASAP? But again, it's all dependent on the profession, the circumstances. And I couldn't agree more. So to wrap this all up, what would you suggest that paramedics could do tomorrow if they have a resus that could coordinate better teamwork and communication?
So tomorrow, if I was a paramedic and I had no chance to prepare other than tomorrow, I would talk to my partner, and I would say, if we get something bad that happens tomorrow, right? Like, let's do a little pre-planning. Who's going to give handover? Who's going to talk to the family? Who's going to be the one to manage the airway? And when we go in there, and it can change like day to day or hour to hour, if one of you is more familiar with one aspect or the other, or you take turns going back and forth, or just by nature of you arriving there, one of you has chosen to do the interventions and speak to the family. But I would do that pre-work. I think a lot of this has to be done in advance. So the first step, I think, would be that. The second thing would be that when you actually get to the hospital, I would be slow, right? I would, and not super slow, but, owing to what we talked about earlier, I would take the time to say, how are we going to move this patient over? Who's in charge if they don't present themselves immediately, right? Who am I going to give handover to? I'd like to give handover now, right? And get that one piece sort of out of the way and be vocal about it. Like say, like, I was hoping to give handover after we move the patient over. Is that all right? Who am I giving handover to, right? And then the third thing I would do tomorrow is try to be as optimal as I can about patching in and giving information in advance. And I know this isn't always possible, and there's a lot of competing responsibilities. But that call that we receive from the field is so important to us, or multiple calls if there are updates. So if that piece could be a priority, it certainly helps on the hospital side.
Incredible. I know they will appreciate this, and I know we'll try to implement those solutions. Yeah, thank you so much, Dr. Pyle.
No problem.
Yeah.
We appreciate you. Yeah, no, thank you.